Okay. Good morning, everybody, and thank you for being with us today. My name is Jenna Sistad, and I'm with the Ocean Monmouth Health Alliance, joined with me today by my colleague, Siobhan. We promote this series every month. Our Health to Hold is something that started during the pandemic and continued through the current. It's a way that we're able to highlight all of our wonderful community partner work and also recognize the National Health Awareness Month. This month in May happens to be National Stroke Awareness Month. And so we have Kim from the Brain Injury Alliance here to take us through some information about stroke prevention, some education, and talk to us a little bit about what their organization offers. So thank you for being with us today. If you haven't already, please put your name and contact information into the chat box and know that there will be time for questions at the end. And thank you again. Kim, take it away. You're up.
Thank you so much, Jenna. Appreciate the opportunity to be here and speak with everyone today. And thank you to everyone who showed up for taking the time to join us for this, I think, really important topic. And hopefully we all enjoy it and learn a little something. So just to get started, my name is Kim Stranero from the Brain Injury Alliance of New Jersey, and I'm a community outreach specialist there. So just to outline what we'll be talking about, we'll talk about what is a stroke, so kind of define it, how to recognize a stroke, signs and symptoms. We'll go over some basic brain anatomy so that we understand what exactly is going on when a stroke occurs. Talk about some risk factors, how to prevent a stroke, and then what the recovery process might look like. So if there's any questions throughout the presentation, please feel free to put them in the chat and I'll be monitoring it from time to time, and I can answer them throughout too. So then to start, what is a stroke? So another name for a stroke is a cerebrovascular accident, CVA. So you may hear it referred to this in a medical setting. And so basically a stroke is a disease of the blood vessels that are supplying blood to the brain. So basically what happens is the blood brings oxygen to the brain. So when the when the blood flow to the brain is impeded, the brain doesn't get enough oxygen that it needs to function normally. Right? So brain tissue that doesn't get enough oxygen begins to die. And so symptoms depend on the part of the brain that's affected. And we'll talk about the two major types. So first we have ischemic. So this is kind of a clot. It's when the artery in the brain becomes blocked, often due to buildup of fatty plaque in the brain or due to a blood clot that travels to the brain. And when the artery is blocked, the normal flow of blood can't get past this blockage. And so the brain cells get damaged, they begin to die because they're not receiving the oxygen or glucose that they need from the blood. And so 85% of strokes are ischemic. So this is the more common type. And so I mentioned that it can be due to a traveling blood clot to the brain. That's called a cerebral embolism. You may hear that. And that's when that kind of starts elsewhere in the body but travels up. And then there's also cerebral thrombosis, right? This is a blood clot that kind of originates in the brain. So those are two different types. Then another major type is hemorrhagic or bleeding stroke. So this is when an artery in the brain bursts, right? And then the resulting bleeding in the brain puts pressure on the brain cells and damages them. So consider someone who's had like a really high blood pressure for a long time. All of that pressure over time can cause the vessel to eventually burst, right? Or you can get an aneurysm. And so an aneurysm is a bulge or a ballooning in a blood vessel in the brain that causes the wall of the blood vessel to weaken. Most aneurysms don't rupture, but a ruptured aneurysm can lead to an hemorrhagic stroke. And so 15% of strokes are hemorrhagic. I'm just looking to see if there's any questions in the chat yet. Okay, not yet. And so what is a TIA? You may hear this term, which stands for transient ischemic attack. This occurs when a blood clot blocks an artery in the brain for a short period of time. Right? So the symptoms of a TIA are the same as a stroke, but they're generally temporary, usually lasting under 24 hours. They may not cause permanent damage, but it is a red flag. So this really serious warning sign that the individual is at risk of having a major stroke down the line, right? So someone who has symptoms of a TIA should receive prompt medical care to prevent a stroke happening down the line and to reduce their overall risk. And so going over signs and symptoms of a stroke. Some signs and symptoms might include sudden weakness or numbness in the face, the arm, the leg, usually on one side of the body, right? And then it can also involve loss of speech, trouble talking, difficulty understanding words or writing, sudden blurred vision, loss of vision in one or both eyes. It may include dizziness, unsteadiness, unexplained falls. And so it's really important to familiarize yourself with these symptoms, especially if you have risk factors for stroke, right? So we'll talk more about these risk factors later on in the presentation as well. So this is a helpful tool to recognize stroke symptoms. It's called FAST. So F stands for face, which might be uneven smile, right? A facial droop, numbness in the face, can have vision changes. Then A stands for arm and leg. So that can be weakness in the arms and legs, numbness, difficulty walking. And again, this is often on one side of the body. S stands for speech. So speech may be slurred. Someone may be using words that don't make sense in the context, or they may be mute or unable to speak. And then lastly, T stands for time. So time is critical. You may have heard the phrase time is brain, right? Because the more time that's passed, the more brain cells are being damaged or dying. And so the longer that someone waits to have an assessment, the more at risk their brain is. So if you have any of these symptoms, it's important to call 911. And so this talks a little bit about what you should do if you're having these symptoms. Call 911 for an ambulance, right? Say you're having a stroke, be very clear that that's the reason why you're calling, and that you need help very quickly. Make sure that the person doesn't drive, because they're potentially increasingly neurologically impaired, right? So sometimes that neurological impairment can become serious very fast. And so even if you feel okay to drive at the time, might be 5 minutes into your drive and all of a sudden you're not anymore, right? And additionally, ambulance staff know where the nearest stroke centers are. So sometimes we'll say, can't a relative just drive me? But the ambulance staff rather are trained to know where the stroke centers are, where to bring people who are having a stroke specifically. And when communicating with ambulance or hospital staff, like I mentioned, always use the word stroke to ensure that they immediately are informed about what's going on, right? And know the seriousness of it. And again, time saved is brain saved, right? So how is stroke diagnosed? It's generally diagnosed through a CAT scan or MRI. So these scans don't necessarily show the effect in the first hours post-stroke. So sometimes doctors will note that clinically it appears someone is having a stroke kind of in symptoms and signs, but it might not show up on these scans right away. And so hopefully if someone shows up at the hospital saying that they're having a stroke, and they recognize the person is having a stroke, they'll hopefully get that person quickly to a CAT scan. So that's pictured on the left. And as I mentioned, as you know, the stroke might not show up right away in the hours after, which is better news than if it shows something, right? Because that means that nothing has happened to the brain for long enough for it actually to show up. So it's kind of more in those beginning stages. It hasn't progressed too much if it doesn't show up yet, right? Part of the reason that they do a CAT scan is because they may want to give that person having a stroke a clot buster, right? So if it is a stroke caused by a clot, they might want to give them a clot buster if they see it in there. But it's important to recognize and see that it's not a hemorrhagic stroke, because of course a clot buster can make the bleeding worse if it is a hemorrhagic stroke. So that's part of why they do this imaging as well. And then the MRI is pictured on the right side. So both of these images are people who have had completed strokes. So you can see that darker region in the CAT scan and that lighter region in the MRI. All right. And then in terms of brain anatomy, just so we understand kind of what's happening in the brain has two hemispheres, the left and the right hemisphere. The right hemisphere controls the left side of the body, the left controls the right. So it's kind of like in an X pattern there, diagonal pattern. And there's all these different regions, right? The frontal lobe, parietal, the occipital, temporal, brainstem, cerebellum. And so depending on the part of the brain that's affected, that determines what symptoms and signs are present. And so as you can see here, motor function is that top part of the brain. Sense of vision might be in that front area that you see, or rather the back. It's kind of flipped in this picture. And then a certain region is responsible for touch, taste, sight. And so again, depending on what part of the brain that's affected, where the tissues are, dying or being injured, that depends on the symptoms. And so there's some non-controllable risk factors for stroke. So I'll just briefly touch on these and then I'll focus more on the controllable factors so that we know what we can do to prevent stroke. So we see that race is a non-controllable risk factor. Black individuals have a much higher risk of death from a stroke than white individuals do because of societal barriers and systems that have harmed their health for decades. Black individuals have a higher risk of high blood pressure, diabetes, obesity, which are all risk factors for stroke. Also, for some Hispanic individuals, the limited availability of Spanish language health information may hinder efforts to prevent stroke. And then age, so we do see that stroke is more common after age 65, but it can occur at any age, right? Familial history. So if a parent, grandparent, sister, brother has had a stroke, especially if they have had that before age 65, you may be at greater risk. And then a person with a prior stroke has a much higher risk of having another stroke than someone who's never had one. So a person with one or more TIAs, so those are the kind of like the mini strokes, is almost 10 times more likely to have a stroke than someone of the same age and sex who has not had, right, TIAs. And if you've had a heart attack, you're at higher risk of stroke, right? Heart attacks happen when plaque builds up in the blood vessels and blocks blood flow to the heart. And so it's kind of similar mechanism in the brain with stroke. And so that's that connection there. And then lastly, gender. So women do have more strokes than men. Stroke kills more women than men. So several factors may increase risk for women. These include pregnancy, history of preeclampsia, history of gestational diabetes, oral contraceptive use when combined with smoking, especially, postmenopausal hormone therapy, changes in hormonal status. All of these can increase that risk. And then here's some controllable risk factors. So I won't go through all of these on this slide because I go through them in more detail on the next slides, but this is just a brief list. So going through them one by one, we see that high blood pressure is a risk factor for stroke. This is the #1 cause of stroke. It's important to know your blood pressure, have it checked. Nearly half of American adults do have high blood pressure. That's defined, you might see it defined as differently in different places, but a lot of places define it as 130/90. It used to be 120/80. Some people still define it as 120/80. I've seen different things. So basically, if you have high blood pressure, this puts pressure on the blood vessels, which can eventually cause them to burst. So it's always important to talk to your doctor, right? How to lower your blood pressure, how to control it. And then increased blood cholesterol. So blood cholesterol can cause fatty plaque buildup in the arteries. And we know that fatty plaque buildup can block the blood flow. And next, diabetes. So having diabetes increases your risk of stroke because it can cause disease of the blood vessels in the brain. So if you have type 1 or type 2 diabetes, it's of course important to control your blood sugar and work with a doctor to ensure that that's well managed. And then smoking, of course, smoking is bad for your health. Smoking damages blood vessels. The nicotine and carbon monoxide in cigarette smoke damages your heart, damages your vessels, makes you more susceptible, right? And next, physical inactivity and obesity. So being inactive, obese, or both can increase your risk of cerebrovascular disease and increase your risk of stroke. So it's important to stay physically active with aerobic exercise and muscle strengthening activities. Um, and then next, excessive alcohol intake. So drinking an average of more than 1 drink per day for women and more than 2 drinks a day for men, just due to metabolism differences, can increase your risk of stroke. That's something to keep in mind as well. And then next we have artery disease, right? Carotid arteries in your neck supply most of the blood to your brain, right? So if you have a buildup of fatty plaque inside the artery wall, that increases the risk of a blood clot forming and then blocking that artery up to the brain. So severe narrowing of the arteries maybe need to be treated surgically. And then TIAs we talked about. So if someone has a history of TIAs, there's mini strokes, they increase the risk of stroke. So recognizing the cause of the TIA and then treating that cause can reduce your risk of a major stroke down the line. And next we have atrial fibrillation or other heart disease. So in atrial fibrillation, the heart's upper chambers quiver, right? So these weak, ineffective contractions of the heart cause blood to pool and clot. So basically, the blood is not pumping effectively. It's not getting all the blood out kind of every time. So the blood is pooling. It can cause clots because it's pooling. And so if a clot breaks off, lodges in an artery leading to the brain, can cause a stroke, right? And then next we have illegal drug use. So intravenous drug use has been linked to stroke. Cocaine, regardless of how it's used, greatly increases the risk of stroke since it's a vasoconstrictor, which means it kind of narrows the blood vessels. So that's something to keep in mind too. And next we have diet. So this is a controllable risk factor as well. We see that someone who consumes high levels of saturated fat, trans fat, and cholesterol can raise blood cholesterol levels, high levels of sodium. So if someone eats a lot of salt, right, it can increase blood pressure. High calorie diets can lead to different complications like obesity that can lead to stroke. So it's always important to consume 5 or more servings of fruit and vegetables per day. They say you should have a colorful plate, right? So vegetables of all different colors, fruits of all different colors, and that can increase or that can reduce the risk of stroke, eating healthy like that. There's also some medications to prevent stroke, so it may be necessary to control chronic health conditions with medication in order to lower stroke risk that may be associated with other conditions. And so I won't talk too much about these because I'm not a doctor, but these are just some options, that are out there that you may want to talk to your doctor about if it's a concern of yours. So these are, there's blood thinners to prevent stroke. All of these are really individualized. So these are some common blood thinners, but of course, talk to your doctor if you'd like more information. And since the stroke affects the brain, and the brain is the control center of everything that we do, think, and feel, if we have a stroke, it can affect any of our functions, right? So it may affect our walking, moving our limbs, our speaking may be impacted, understanding speech, oftentimes swallowing is impacted. So we'll talk more about different professionals that may be involved in the rehab care, but a speech language pathologist might help with swallowing, speaking. We also see memory impairments can take place. So that can be short-term memory or long-term memory, how you think, feel, and behave. So sometimes people have personality changes or kind of behavioral differences after stroke. Their senses of sight, sound, and touch may change. So their vision and kind of the way they perceive sound. And the urination may also change, right? So just these functions that we don't even think about throughout the day as we move through our lives might be impacted for someone who has had a stroke. And I should mention, so that's just a limited list. It can be way beyond this too. There's other symptoms and the list goes on and on and on. But these are some of the more common symptoms that I wanted to highlight. And so when considering the question of when will I get better, it's helpful to note that swelling and blood in the brain resolves over months. So Luckily, the brain does have the ability to heal itself, to remodel. Rehab is not is meant to facilitate the recovery, right? So when you go to rehab, when you see all these different rehab professionals, it's meant to kind of help this process of recovery along. Um, and recovery continues for at least 6 to 12 months and can often continue for longer. So oftentimes we'll hear from someone who said, I was told that after the 12-month mark, I'm done and I can't make any more progress. And that's just not the case, right? We see that it's often, 6 to 12 months, but it can be longer in many, many cases. So it's important not to, give up on your progress, continue on even if it's past that year mark. And even after the brain recovery completes, new learning can still occur. Right. So we have really flexible brains, right? And their ability to heal themselves is pretty significant. We talk about neuroplasticity when different parts of the brain can make up for other parts that may be lacking. So always good to hold on to hope and continue with that rehab. And next steps. So, like I mentioned, the goal of rehab is improving functionality, reducing mortality, and addressing different impairments that may be present. So I'll go through kind of different types of rehab one by one. So it may be helpful for those who have loved ones who are going through this process now, or just good to know, in general. You never know what might happen. So what is acute inpatient rehab? This is an intensive form of medical rehab, medical rehabilitation, where the person receives at least 3 hours a day of core therapies, 5 days a week, right? So this is pretty intense. The core therapies often are PT, right? Physical therapy, occupational therapy, speech therapy. And this type of rehab is often overseen by a doctor who specializes in rehabilitation. There should also be around the clock care, with nurses, team of doctors, therapists who are all working together to restore the person's function. Right, so this is a pretty intensive form. And we'll often get this question of how do I choose a rehab facility? So, of course, it's important to consider if it's covered by the patient's insurance. Does the staff have experience and expertise in stroke? Can the facility meet other medical issues or needs that the person has? So if the person has, say, other physical limitations, or if they have diabetes, can the facility handle that? Are they informed about those things? And then lastly, is the location convenient for friends and family to visit? So we know in the recovery process, staying connected with family and friends is so key to success, right? And so we don't want the rehab facility to be really far away where friends and family can't visit and the person is isolated, because that can actually affect the success of the rehabilitation process, right? And then what kind of issues are addressed? So oftentimes issues with memory, language, concentration, judgment, problem solving, all of these more cognitive issues might be addressed. Physically, if someone has loss of strength, if they have, that weakness in their limbs, balance and coordination issues, swallowing difficulties, those things might be addressed. Sensory wise, someone might have changes in smell, sight, hearing, touch, those things might need to be addressed. So, for example, if someone's having issues with vision, they might need to see a vision specialist, like an ophthalmologist or a neuro-ophthalmologist. And then also emotionally. So, someone might have changes in mood, changes in personality, issues with impulsivity or anger or irritability. So those things can be addressed through different therapies as well. So who is eligible for inpatient rehab? Usually it's a patient who has a new stroke with impairments. If a patient is medically stable enough to participate in 3 hours of daily therapy, right? So that really intensive rehab. If they have insurance that approves, of course. And if they can make progress in therapy. So if the impairments are not too severe that they would prevent progress. And if the patient was previously independent and now they're not able to be safely discharged home alone, that they're probably a good candidate for inpatient rehab. And just to briefly go over the members of the rehab team, they might see a doctor, right? So some types of doctors that might be involved are uh, neurologists, that I would say that's one of the more common types, cardiologists, physiatrists, right? So a physiatrist is a doctor whose focus is rehab medicine. Um, and then, cardiologists, like I mentioned, other types of specialists might be involved. And their role is basically to assess the physical capabilities, assess different changes that took place, prescribe medication as needed, prescribe these tailored therapies, and order tests and treatments to analyze, maintain, improve the health of the patient. And then rehab nurses might be involved as well. So they play a really critical role in stroke rehab, working very closely with the doctors. They administer medications, they work to prevent medical complications that can occur, assess the patient's ability to care for themselves, right? So considering things like bladder function, bowel function, diet, movement, and they also look at safety measures and precautions. And then psychologists and neuropsychologists will often play a role as well. So they can assess and treat symptoms related to mood, behavior, agitation, memory, and they're often involved in counseling, not only the patient, but also the family, right, through the process afterwards. And then physical therapists are a really key member of the team. They can help the patient improve their physical function and abilities, how to be independent, safe as possible in their environment. They'll be given exercises, right, to retrain their muscles, retrain their nerves, oftentimes given homework to do at home afterwards too of these exercises. And the aim here is to strengthen muscles, improve endurance, walking, and balance, right? Because we also don't want a second, say a fall to occur after a stroke either, sustain another brain injury. So it's important to get that function back and that strength back. And then occupational therapists will often work with patients on their ADLs, which are activities of daily living. These are things like eating, bathing, grooming, dressing, with the goal of increasing independence. So they might help transfer the person in and out of the bed or the wheelchair, on and off the toilet, in and out of the shower. They may also help with assessing, cognitive skills, memory, vision changes, sometimes even. They might help with kind of managing more complex tasks like meal prep, cooking, medications, and recommending any equipment that may be necessary for the person to go home. And then SLPs, speech language pathologists, will, like I mentioned before, treat issues related to swallowing and communication. And so they can help the individual with articulating speech, understanding other people's speech, strengthening the actual muscles used in speech, right? If there's some weakness there, they can assess the ability to swallow, recommend dietary changes, to make sure that the person can eat or drink safely. So for example, if someone has an aspiration wrist where they breathe liquid into their lungs, they might recommend that the person uses like a thicket to thicken their liquids. And they can assess language, memory, problem solving, right, attention, reasoning. So you might notice that there is some overlap between PT and OT, and then OT and SLP, right, speech language. And so that's why it's so important for the team to all work together to make sure they're not, duplicating unnecessarily, to make sure that they're using interventions that complement one another. So the team effort is so, so important. And we have recreation therapists. So they will often find activities to improve patient well-being based on the individual's hobbies and interests, right? So if someone was a huge golf fan before, the recreational therapist might find ways to incorporate that interest in their recovery, right? So that may be playing games, going on outings, going on social events, depending on the person's interests. And then social workers are great sources for community resources, right? Help with discharge planning, helping the person to return to the community successfully, um, and helping figure out what benefits the patient is eligible for. So they can help handle insurance hurdles, which is huge, right? And so it's really important to work with that social worker. They're often involved early and late in the process. So they'll work with the team to make sure that the person has appropriate resources in place. And then lastly, we do have a nutritionist and dietitian on many teams. And so they can assess food intake, make recommendations for diet changes. Patients are often underfed and need more nutrition than they did before the stroke because the brain is trying to heal. It needs more energy going up to it to heal. Um, you often need a higher level of caloric intake, protein intake during that recovery period. So it can be important to see a dietitian about that. And then the role of the family. So the family plays a really, really important role in the rehab process. Oftentimes, family members want to know what they can do to help, right, during this process. So it's important to get to know the team members, their various specialties, keeping an open line of communication with the team, right, asking about the patient's progress. And as the team gets to know the patient, oftentimes the family, especially the caregiver role, might be called in to get some hands-on training so they can continue that level of care that they were getting in the rehab facility at home. Right. So go into a family training session, particularly as it gets closer to that discharge date, can be really helpful. And it also can be helpful to ask about the discharge process early on. So acute rehab stays are often really short, like 2 to 4 weeks. Oftentimes that's all insurance will cover is like 2 to 3 weeks, up to 4 sometimes. So it's important to know what the discharge process will look like at the end and to be there to emotionally support the patient on their journey, right? Encouraging them to hold on to hope and stay positive. And in terms of what happens after inpatient rehab, leaving the rehab is a change that may cause anxiety. It can be a huge change. Someone may be concerned about what that transition might look like. So just knowing that the social worker and team are there to assist you in accessing what services might be out there, what insurance will cover. Every discharge plan is very specific and different for the patient situation. So it's always important to individualize this as much as possible. And then most people will need ongoing therapy after they leave. So that can be things like PT, OT, speech language pathology, all the different things that we talked about. And discharge plans often will involve a discharge home with home-based rehab services, right? So that might be for someone who is able to go home, but not well enough to travel to an outpatient rehab. So rehab therapists will come to the person's home, do their therapies there. It also may include, say, having a home health aide a few days a week. And even when there is home care, the family themselves are often called upon to provide some of the care and the supervision at home. So family is almost always needed as well. And there's also discharge home with outpatient services. So if a patient is well enough to go home and then travel to an outpatient therapy clinic, the family will provide the care and supervision at home, and then the patient will travel to a external facility for their therapies. And they also might be discharged to a nursing facility or subacute rehab. So sometimes this is the recommendation, which generally involves 2 or less hours of inpatient therapy a day. This is for patients who are not ready to go home full time. They might need more therapy in a more structured environment. And so that type of facility provides nursing care and therapy in kind of specialized rehab wings for patients that have the goal of going home eventually. Right? And how long they stay is often based on their medical needs, progress, rehab needs, insurance, and should be tailored to them. So oftentimes, again, social workers will be involved with finding a facility along those lines. So in summary of what I just talked about so far, strokes are caused by injury to the brain, right, from blood vessel disease. Impairments seen after stroke are very much based on the part of the brain that's affected, because we know different parts of the brain are responsible for different functions. Your brain is your world, right? So everything we do is dependent on our brain, helping us with different tasks and really running the show, right? It's the control center. So we need to be aware of these things that we can do to minimize our stroke risk. And it's important to recognize that recovery occurs for months, if not years after, right? So there's not that myth of it stopping after a year, right? Stopping after 12 months, that's not true. It's important to continue on, and progress can be made even after that point. And rehabilitation facilitates recovery after stroke. So that can really help to maximize the person's function and their quality of life. So now I'm going to just briefly go into some of what we offer in terms of services. But before I do that, are there any questions at all? I'll look in the chat.
I don't see anything in the chat, but if anybody wants to come off mute and ask them a question, that would be welcomed as well.
Absolutely.
I have a couple, but I'm going to keep mine to the end because I have a feeling you're going to talk about some of this stuff.
Perfect. Sounds good.
Yeah.
Any questions? And then I'll ask again at the end too. So if anyone has any questions that they want to hold till the end, that's fine too. Okay, so just going briefly into our services, we do have, so we're a statewide nonprofit, and we are funded primarily by the state, by DDS. And so our services involve many different supports for people with brain injury. And so, for example, we have a care management program. That program is kind of a resource facilitation program for individuals with brain injury. We can help with navigation of services, right? Pointing to appropriate services, and help with filling out forms, attending meetings, familial support, caregiver support, emotional support, all these different things. And then for support groups too, we have all different support groups all over the state. Some are in person, some are virtual, and many are specific to survivors, some are specific to caregivers. And then we also have our social groups. So if someone doesn't want a support group, they don't like the idea of the structure of that, then they can always just join for a social group to meet other people who might be in a similar boat. And then we also have a peer mentor program. So if someone recently sustained a brain injury and they're not sure where to turn, we can help set them up with a peer mentor to help them with those initial steps, right? And kind of how to navigate the changes. And then we also have caregiver peer mentors, right? For someone's new to caregiving. We also have 2 camps. So we have Camp Trek, which is for adults 18 plus with brain injury. We do have many stroke survivors that come to Camp Trek every summer, and that takes place in August. And then we also have a family camp for families impacted by brain injury. That's coming up this June, and the whole family unit can attend that one together. And I think that's pretty much it for the support services. And we also have different educational initiatives, right? So we're often in the community, we'll do tables, we'll do all different workshops, about concussion, stroke, fall prevention, all different topics. And then we'll work towards prevention of brain injury. So we do have many transportation safety initiatives within the school systems and within the community. And we work to provide advocacy at the state level to advance the needs of people with brain injury. Something else I should mention too is we do have a helpline. So if there's any questions about brain injury resources that are out there, questions about brain injury in general, that helpline can be called, and I believe that's on another slide. And we can help you navigate any question that you have. And I should also make this very clear that stroke is a brain injury. So I keep saying brain injury during this part, but if someone knows someone with a stroke, that is very much included, under that umbrella. And even things like aneurysms. We have people who have anoxic brain injuries, lack of oxygen going up to the brain. That can be from overdoses or near drownings, for example. And we have people who have had meningitis, brain injury from meningitis. So it's not just your classic TBI, right? So I wanted to say that too. This is a little bit of what I just talked about, right? We have all these different programs. That's the helpline. So if anyone's interested in that, that's the number. And then I will briefly touch on the TBI fund. So this is through the state, it's through DDS. And it's a fund of last resort for services and supports having to do with brain injury. So this is specific to TBI, but I just want to mention it briefly. Someone can get up to $15,000 per year towards brain injury supports. And so if you have any questions about that, you can reach out to. And in terms of education, I mentioned that we do these workshops. We'll often do community events. We do have webinars once a month. So next month, in June, we do have one about chronic traumatic encephalopathy, CTE. We also have one about veterans and brain injury. We have regional trainings every March for health and human service professionals. And then I mentioned our school programs for transportation safety and our advocacy network as well. And so I'm just looking to see if there's any other questions. Yes, I can post the number. Absolutely. I'll put that in. And are there any other questions in the meantime as I'm putting that in the chat? I'll just go ahead and put that in the chat.
Okay, while you're putting that in the chat, I'm gonna kick us off with questions.
Sure.
So you mentioned that the ambulances have information about where the closest stroke centers are.
Yes.
And I'm wondering if you have any names or a comprehensive list of stroke centers that are in Monmouth and Ocean County specifically, or, we'd take a statewide list also, just to share with folks that may have interest or have the need. I myself did not realize that, there were specific stroke centers. Um, so that is fantastic. And I wish that I would have known about that, when my dad was going through all of this.
Yeah, absolutely. So I can definitely get a list of that. I'll reach out to our community resource specialists who I'm sure have that information. And I can definitely send that to you for sure. Yep.
Okay, perfect. Then my second question is about the risk factors. You talked a lot about the controllable and the uncontrollable risk factors, and just wondering if you have heard of any risk factors associated with marijuana use and or vaping. Like I hear a lot about how harmful vaping is and for your heart and your brain. And I'm just wondering if there's any connection with stroke there.
Yeah, good question. So vaping, so for neither, I haven't heard like specific research, but I know that for vaping, oftentimes there's heavy metals involved in the vapes, and so that can cause damage to the vessels, which can lead to stroke, I would think down the line, and also can cause brain injury in and of itself because heavy metals can lead to neurotoxic poisoning. So that's kind of my first thought with vaping. I'm honestly not sure about marijuana. I don't know if there's been research into that. I have not seen any, like I said, but I'm interested now, so I will definitely look into that and I'll keep you posted.
Thank you. Yeah, I was
Course.
thinking the same thing about the like the heavy metals and all those toxins in the vaping.
Mhm. Yeah, absolutely. And even just the chemicals, that are in there sometimes that people are inhaling, um, definitely not good for you.
Yeah. And then finally, this is kind of more of like a FYI or a share for folks that are here. You mentioned a lot of things with the inpatient services, outpatient services, subacute rehabs, and how families can be involved. And I think you mentioned it, but I wanted to make a special emphasis about family advocacy. Like, it's one thing to be there and involved in the therapies but really sometimes some of these facilities, it's about the bottom dollar for them. And so it really is up to the loved ones of the person who has had the stroke to kind of push for some of these additional services. There were times for us that they would say, oh, your dad's only, he's not making great progress. So we're, he would be entitled to 5 days a week, but we're really only going to be doing therapies with him 3 days a week. And we would have to really get the team and have a meeting and be like, no, our insurance pays for the 5. We are wanting the 5. And like, can really impact the success of the recovery when you push for some of those things. And that was just an example, I feel like, of advocacy. But all around this whole process. You know, from the prevention side to the recovery side. Advocacy of our loved ones is so needed. So thank you for mentioning that earlier, Kim.
Yeah, absolutely. And thank you for elaborating on that. That is so important. Like you had mentioned, sometimes the facilities, it's about the bottom dollar, or they're trying to just get people in and out as fast as possible. So sometimes it's important to advocate for a longer stay or advocate for those, additional therapies and supports. So definitely really important.
And it
Um,
is overwhelming too. So being able to rely on an agency like yours to kind of help facilitate some of that messaging or know your rights type of stuff, like is really valuable to the family.
Absolutely. Yeah, if we could ever help anyone with, any brain injury, stroke related need, please feel free to reach out. We'd be more than happy to support. Also, I should mention too, if aphasia is a concern that comes up, which is kind of this communication difficulty after brain injury. There's a great place called Aphasia or Adler Aphasia Center. I don't know if you've heard of it, Jenna. Um, and it's in a few locations, but one of the locations is Tom's River. And it's basically like a community-based communication group model. And so patients will go and they'll join these small groups, sometimes do one-to-one of kind of aphasia-based communication practice. It's a really, really cool nonprofit. I would recommend them as well.
I have not heard of them. Thank you so much for mentioning it. I'll tell my mom
Yeah, of course, of
because they
course.
live right in Tom's River. And so for us to not know about that, the social workers that are doing our inpatient outpatient discharge did never mention that. So thank you for sharing it.
Yeah, of course. And if you would like me to put you in touch with them as well, please let me know.
Yes, please. I would.
Yeah, absolutely.
Okay,
And
so
any other
that's
questions?
enough from me. I'm sorry that I hijacked the meeting, but thank you for answering my questions. And does anybody else have questions for Kim or comments, something to share? Please feel free to put it in the chat or take yourself off mute.
Anything else? And thank you, Jenna, for your questions. I think they were really important questions to bring up.
Thanks.
Anything else? And if anyone has any questions they're not comfortable sharing today, too, please feel free to reach out to me via email. My email's on the slide, and I'm more than happy to answer your question, one-to-one like that, too. All right. Well, thank you so much for having me. I appreciate it.
All right, I'm just throwing your email in that chat box one last time. We
Perfect.
have Tracy telling us thank you. This is a great presentation, and I agree, Tracy. Thanks for being here with us.
Thanks so
I'm going to
much,
do a
Tracy.
last shout out for questions.
Anything else?
And hearing none, seeing none in the chat, we'll give you 10 minutes back in your day. And just thank you again, Kim. And thank you to the Brain Injury Alliance for being here today, providing this information. Our Help to Hold webinar series session will be on June 25th from 10 to 11 a.m. And it is National Cancer Survivorship Month. And so we will have Meg Macquarie from the Elixir Fund with us talking to us about cancer survivorship. And we hope to see you there. Thank you guys. Have a good one.
Thanks so much. Have a good one.